Evaluating suspected dementia requires a comprehensive and systematic approach, moving beyond simple observation to encompass a thorough clinical picture. The process relies heavily on a multifaceted assessment, starting with detailed historical accounts and progressing through specific diagnostic tools to differentiate between various cognitive impairments. A crucial first step involves gathering a reliable collateral history, as a patient's self-report is often compromised by poor insight, known as anosognosia, or a desire to downplay symptoms. Family members or caregivers are invaluable sources for understanding the timeline of functional decline, the progression of symptoms, and any notable behavioral changes. Following this, an initial in-clinic cognitive screening test, such as the mini-cog, helps quickly assess cognitive function. Should this brief screen be abnormal, or if clinical suspicion remains high, a more detailed tool like the Montreal Cognitive Assessment, or MoCA, is indicated to better characterize any deficits. It's worth noting that tools like the Roland Universal Dementia Assessment Scale, or RUDAS, are also available, specifically designed to minimize educational and cultural bias in cognitive screening. Beyond historical accounts and screening, a targeted physical exam is essential. This exam aims to identify focal neurological deficits, signs of Parkinsonism, or gait abnormalities that could point towards a particular dementia subtype or even an alternative, treatable diagnosis. Moving from the physical exam, a focused lab workup plays a critical role in uncovering reversible or contributing causes to cognitive decline. Standard tests include a complete blood count, a comprehensive metabolic panel, thyroid-stimulating hormone, and vitamin B12 levels. While folate deficiency is rare in fortified countries, it is still often included in many guidelines. These basic tests can reveal mimics or significant contributors, like anemia, electrolyte disturbances such as hyponatremia or hypercalcemia, renal or hepatic dysfunction, hypothyroidism, or vitamin B12 deficiency. Depending on a patient's history and specific risk factors, additional screening for conditions like syphilis or HIV may also be warranted. Following the initial lab investigations, non-contrast brain MRI stands out as the preferred imaging modality. Its primary role is to rule out structural lesions that can cause cognitive decline, such as subdural hematomas, normal pressure hydrocephalus, intracranial tumors, or evidence of prior strokes. While a normal MRI doesn't definitively exclude dementia, it is vital for identifying these secondary causes. In situations where an MRI is unavailable, a non-contrast head CT serves as an acceptable alternative. Imaging can also offer clues about specific dementia subtypes. For example, Alzheimer's disease may initially show normal results, but later reveal medial temporal lobe atrophy, particularly in the hippocampus. Frontotemporal dementia might display frontal and/or temporal lobe atrophy, while leukoariosis, an abnormal change in white matter, can indicate vascular dementia. Despite the existence of advanced biomarkers, the diagnosis of dementia remains primarily clinical and does not routinely necessitate CSF analysis or PET imaging for most patients. A thorough history, cognitive testing, basic labs, and imaging usually provide enough information for a confident diagnosis. However, specialized tests are reserved for atypical presentations, unusually young onset cases, or when a specific diagnosis is needed to determine eligibility for novel amyloid targeting therapies. In these specific circumstances, CSF analysis for amyloid beta 42 and tau proteins, along with amyloid and FDT PET imaging, can increase diagnostic certainty, especially for Alzheimer's disease. One unique insight from PET imaging is the cingulate island sign on an FDG PET scan, where metabolism in the posterior cingulate is spared relative to the precuneus and cuneus, which is highly suggestive of Lewy body dementia. A distinct yet important transitional state is mild cognitive impairment, or MCI, characterized by objective cognitive decline without significant functional impairment in daily life. Individuals with MCI show deficits on cognitive testing but maintain independence in their activities of daily living. Approximately 15% of individuals with MCI convert to dementia per year, though interestingly, about 26% may revert to normal cognition on follow-up testing, highlighting the dynamic nature of this diagnosis. The Mini Mental State Examination, or MMSE, is often used, but it's less sensitive than the MoCA for detecting MCI and the executive dysfunction common in non-Alzheimer's dementias. When considering specific types of dementia, Alzheimer's disease classically presents with insidious, progressive episodic memory impairment. Early symptoms typically involve difficulties recalling recent events, repeating questions, and struggling to learn new information. The presence of early or prominent gait disturbances, tremors, vocal weakness, or seizures should prompt consideration of an alternative diagnosis. It's also worth noting that up to 40% of older adults with dementia have mixed pathology, most commonly a combination of Alzheimer's disease and vascular dementia. Another significant subtype, dementia with Lewy bodies, or LBD, is strongly suggested by the presence of visual hallucinations, Parkinsonism, and significant cognitive fluctuations. patients often report well-formed visual hallucinations, such as seeing people or animals that are not there. They typically exhibit spontaneous Parkinsonism, including bradykinesia, rigidity, or tremor, along with hour-to-hour or day-to-day fluctuations in cognition and alertness. A critical consideration for these patients is their severe neuroleptic sensitivity. Administering typical antipsychotics like Haldol can lead to irreversible Parkinsonism, profound sedation, or even neuroleptic malignant syndrome. An interesting related fact is that REM sleep behavior disorder can predate the cognitive and motor symptoms of synucleinopathies like LBD and Parkinson's disease by years or even decades. Vascular dementia should be suspected in patients with cerebrovascular risk factors. While classic teaching describes a stepwise decline where cognitive function abruptly worsens after a stroke and then plateaus, it can also manifest as a smooth, gradual decline, especially in cases of small vessel disease. The specific cognitive deficits depend on the location of the vascular injuries, but commonly involve challenges with executive dysfunction, impacting planning and organizing abilities. A history of hypertension, diabetes, atrial fibrillation, and prior strokes should heighten suspicion for this type of dementia. Finally, frontotemporal dementia, or FTD, is distinguished by prominent early changes in personality, behavior, or language, rather than memory. The behavioral variant of FTD is characterized by socially inappropriate behavior, a loss of empathy, apathy, and compulsive behaviors, with memory often being relatively spared. The language variant of FTD, on the other hand, presents with progressive difficulties in speech production or word comprehension, known as aphasia. Throughout the evaluation process, it is also paramount to always assess the patient's anticholinergic medication burden, as it is a common iatrogenic cause of cognitive impairment in older adults.